For over 40 years, one tiny pill was seen as daily protection against heart attacks. Doctors told millions of people, take a baby aspirin every day. It was cheap, easy, and it sounded safe. Then in 2022, major medical guidelines changed. Suddenly, many people were told to stop. For some adults, daily aspirin may now do more harm than good. So what changed? Did aspirin stop working? Or did we misunderstand who actually needs it? Because whether aspirin protects you or increases your risk depends on a few things most people never check, and that's the part no one explained clearly. Aspirin works by calming down platelets. Platelets are tiny cells in your blood that help it clot. When you cut your finger, platelets stop the bleeding. They save your life. But inside your arteries, clotting can be dangerous. Most heart attacks don't happen because an artery slowly closes. They happen because something suddenly blocks it. And that something is usually a clot. So the logic made sense. If clots cause heart attacks and aspirin reduces clotting, then aspirin should reduce heart attacks. And in higher risk patients, it absolutely does. But biology is never that simple, because preventing clots everywhere in the body has consequences. Over time, fatty deposits called plaque build up in your arteries. Some plaque becomes hard and stable. Other plaque stays soft, inflamed, and unstable. That soft plaque is the dangerous kind. If it cracks open, your body reacts as if you're injured. Platelets rush to the site. A clot forms rapidly. If that clot blocks the artery, blood can't reach part of the heart. That's a heart attack. Notice something important. The plaque might not have been blocking much blood flow before it ruptured. It's not always about how blocked the artery is. It's about how unstable the plaque is. And that changes how we think about prevention. Aspirin doesn't only affect your heart, it affects your entire body, especially your stomach. Your stomach lining protects you from your own acid. Aspirin weakens that protective layer. Over time, daily aspirin increases the risk of stomach irritation, ulcers, internal bleeding, and in rare cases, bleeding in the brain. For years, doctors believed the heart benefit outweighed this bleeding risk. And in high-risk patients, it still does. But newer studies looked at healthier adults, people who had never had a heart attack, and the results surprised many physicians. In these lower-risk adults, aspirin prevented very few first heart attacks, but bleeding complications still occurred. So for many healthy adults, the risks and benefits began to cancel each other out. That's why guidelines changed, not because aspirin stopped working, but because medicine became more precise. Today, doctors separate people into two categories: primary prevention and secondary prevention. Primary prevention means you've never had a heart attack, never had a stroke, no stents, no bypass surgery. You're trying to prevent your first event. For many adults over 60 in this group, daily aspirin is no longer routinely recommended. Now, secondary prevention is very different. If you've already had a heart attack, your arteries have proven they can form dangerous clots. In this case, aspirin clearly reduces the risk of another event. Here, the benefit outweighs the bleeding risk. So the real question isn't, is aspirin good or bad? It's, which group are you in? And surprisingly, many people don't actually know their true risk, because they've never looked directly at their arteries. A lot of people rely on stress tests. You walk on a treadmill. Your heart rhythm is monitored. If the test is normal, you feel reassured. But stress tests usually detect severe blockages, and many heart attacks happen before arteries are severely blocked. You can pass your stress test and still have unstable plaque. That's because stress tests measure blood flow limitation. They don't measure plaque vulnerability. So what gives better insight? Imaging. Actually seeing the arteries. A coronary calcium scan takes about 5 minutes. It's a low radiation CT scan that looks for calcium in the heart arteries. Calcium indicates plaque has been present for years. If your calcium score is 0, your short-term risk of heart attack is very low. In that case, aspirin usually provides little additional benefit, but if calcium is present, that means plaque already exists. Now the conversation changes. Now prevention becomes more targeted. Another option is carotid ultrasound. It examines the arteries in your neck. It can detect early plaque even before symptoms appear. Instead of guessing your risk, you measure it. And that measurement can change whether aspirin makes sense for you. Atrial fibrillation, or AFib, is a rhythm disorder. The upper chambers of the heart don't beat normally, they quiver. When blood sits still inside the heart, it can clot. If that clot travels to the brain, it causes a stroke. But here's the key difference. Heart attack clots are mostly platelet-driven. AFib clots form through a different clotting pathway. Aspirin mainly affects platelets. So in AFib, aspirin is usually not strong enough. That's why doctors prescribe stronger anticoagulants instead. For many patients with AFib, aspirin alone gives a false sense of protection. There's another piece most people never check: lipoprotein A, or LPA. It's a genetically inherited cholesterol particle. About 1 in 5 people have elevated levels. Most have no symptoms, but high LPA increases plaque formation and clotting risk. If heart disease runs in your family, testing LPA can uncover hidden risk. Some evidence suggests people with high LPA may benefit more from aspirin than those without it. Same medication, different biology, different outcome. There's another layer to this conversation. Clots don't form in isolation. Inflammation makes plaque more unstable. Poor sleep, smoking, uncontrolled diabetes, high blood pressure all increase plaque vulnerability. No pill replaces lifestyle. Even in people who need aspirin, it works best alongside stable blood pressure, controlled blood sugar, healthy cholesterol levels, regular physical activity. Medication lowers risk, but lifestyle lowers it further, and sometimes dramatically. Some people ask about natural alternatives. Omega-3 fatty acids may mildly reduce clotting. Turmeric may reduce inflammation. Nattokinase may influence clot breakdown. These can support cardiovascular health, but their effects are modest and less predictable. When risk is high, doctors rely on therapies with strong clinical evidence. Natural strategies can complement a plan. They rarely replace medical treatment when risk is significant. So what should you do? Step 1. Measure your risk. Don't assume. Consider a calcium scan. Consider LPA testing. Discuss imaging with your physician if appropriate. Step 2. Know your category. Primary prevention, secondary prevention, AFib. Step 3. Match the treatment to your biology, not to outdated advice, not to internet headlines, not to what someone else takes. The era of everyone takes aspirin just in case is over. Prevention today is personalized, data-driven, risk-based, individual. Aspirin isn't good, and it isn't bad. It's powerful, and powerful tools only work when used in the right situation. The real danger isn't the pill, it's not knowing your true cardiovascular risk. When you understand your risk, the decision becomes clearer. If this helped you understand the nuance behind aspirin and heart prevention, subscribe for more clear, science-based breakdowns. Stay curious, stay informed, and stay proactive about your health, because the best prevention strategy is the one that fits you.